Hello, good evening, friends. So today we have an expert talk as well as the panel discussion from the ICS sleep certification course headed by President J.K. Samaria, Dr. J.K. Samaria, and Dr. Rajadhar and Dr. Amita Nene. So today the topic of discussion is going to be impact of sleep disorders on chronic respiratory disorders and pediatric sleep disorders. I know that this is something which is going to excite most of you here because as a pulmonologist you will be seeing many of such patients, and most probably we may still find a lacuna in our knowledge when we handle these sort of complicated patients. So without wasting much of the time, so I would like to introduce our first speaker. Can we have the CV of Dr. Nitesh Gupta? So Dr. Nitesh Gupta, he's like my senior, my friend, my brother. We did DM together from Saftarjung, and an amazing person and a very good mentor for many. So he is currently working as an associate professor at Saftarjung Hospital, New Delhi. And his key areas of interest include COPD, ILD, and he does a lot of research work, especially involving systematic reviews and meta-analysis. So today he is there with us to speak on sleep disorders and chronic respiratory diseases, the notorious nexus. Over to you, Dr. Nitesh, for your talk on this topic.
Right. Can I have the for the slide deck visible? Is the slide deck visible?
Yes, sir.
Okay, thank you. So at the onset, I would like to thank the ICS team, the President Dr. Samaria sir, Amita Nene ma'am, Dr. Rajadhar sir, and Dr. Vishwesh for the kind introduction. So we are going to discuss a lot of, in next 15 minutes, something which is very common, but goes unsuspected. And in the end, by the time we realize it is quite late. So sleep disorders and chronic respiratory disease, they both share a bidirectional relationship. How? Because chronic respiratory disease has a patient has a very poor sleep quality. This may be because of the symptoms. Patient has disease specific symptoms like dyspnea. The drugs which we give, the pharmacological intervention may cause sleep disturbances and associated biochemical alterations of the sleep and circadian rhythm, which happens in these patients. On the other hand, sleep disorders can affect the underlying respiratory mechanics, underlying ventilation, and underlying gas exchange. In the next slide set, we'll see how does this happen. So what happens usually in sleep, you have reduced cortical inputs, you have reduced respiratory sensor sensitivity, you have reduced chemoreceptor and mechanoreceptor sensitivities, you have reduced respiratory muscle contractility, and you have decreased FRC as well as increased airflow resistance. This is what happens in everybody's life in sleep. Now, when this happens in a patient who already has a compromised respiratory mechanics, all these factors contribute and lead to hypoventilation, hypoxemia, and hypercapnia, which first begins in sleep. And as the stage progresses or when the sleep disorder remains undiagnosed as well as untreated, this moves to diurnal hypercapnia, that is daytime hypercapnia also happen. So if we see in overnight, the decrease in PaO2 is by 3 to 10 mmHg, with which if we see by SpO2, it is around 2%, and PCO2 increase by 2 to 8 mmHg during sleep as compared to awake state in a normal individual. So a normal individual is able to, with his respiratory mechanics, is able to overcome these changes. Even a fall of 10 PO2 does not affect it, or even a rise of 8 millimeters of mercury of CO2 does not affect his overall mechanics. But in patients with chronic respiratory disease, even a slight fall in PO2 or slight rise in PCO2 may land up in them in respiratory failure. So this is a famous ODC curve, which we used to read right from the first year of MBBS till probably till a pulmonologist will have to do it till the end of his practice. So on, if we go and see, this is the ODC curve, which we see that there is a flattened portion and then there's a steep downhill. So when you have an SpO2 of about 80 and above, from your awake to asleep, it falls minimally and does not affect anything. But if you have a patient who has a chronic respiratory disease and has an awake SpO2 on the steeper part of this ODC curve, he has a rapid fall for the same duration of sleep, and the sleep may cause hypoxemia to even to less than 40 mmHg. So this is how the physiology changes just with the normal sleep. So what happens in sleep? There is nocturnal hypoventilation, that is fall in PO2, increase in PCO2. This hypoventilation, to compensate all this, patient has frequent arousals. Once patient has frequent arousals, the sleep is disturbed. This leads to poor quality of sleep. Patient doesn't sleep in night, and there, as a chronic response, there is decreased ventilatory drive to CO2. That is, even if CO2 started rising, patient doesn't increase his minute ventilation to wash out that CO2. Once you are waking up frequently in night, what you start doing is you start compensating by sleeping in daytime. Then again, what this happens, you sleep sometime, you wake sometime, you sleep sometime, wake sometime. This lead to multiple episodes of micro and macro sleep, again leading to hypoventilation. If you have a elevated PCO2, the body will try to compensate by retaining the bicarbonate through the kidney to keep the pH normal. Once the pH is normalized, again there is a decreased respiratory drive. So overall, everything reduces right from the CNS to the peripheral muscles and leads to hypoventilation. Once this nocturnal hypoventilation remains untreated, it spills over into daytime and leads to diurnal respiratory failure. So this has all been the pathogenesis as well as the physiology of why respiratory failure happens in patients who have chronic respiratory disease as well as coexisting sleep disorder. Now, when we talk about sleep disorders in respiratory disorder patient, it is not just the obstructive sleep apnea. We talk about insomnia, we talk about restless leg syndrome, we talk about obstructive sleep apnea and sleep-related hypoventilation. These are the four most common sleep disorders. Again, we just don't talk about obstructive airway disease. We can then have them in even in restrictive lung diseases also. As we can see, ILDs have a very high prevalence of insomnia. If you see RLS, again, ILDs have very high prevalence. If you have obstructive sleep apnea, again, COPD, the prevalence is right from 3% to somewhere around 70%, which is again very, very high. We'll see why does this happen. And sleep-related hypoventilation, most common in COPD. And again, neuromuscular disease patients are the first where they will have hypoventilation during sleep. That is, they will have hypercapnia during sleep, and then they will progress untreated to daytime hypercapnia. So we'll talk about majorly we'll talk about obstructive sleep apnea, one of the most common prevalent disorder. When that coexisting chronic respiratory disease is there, as well as a sleep disorder is there, we call it as overlap syndrome. Most common discussed topic is COPD and OSA, but if it is ILD and OSA, it will also be caused as overlap syndrome. If it is asthma and OSA, it will again be caused overlap syndrome. So when we particularly talk about OSA in COPD, the prevalence ranges 3% to 70%. That is, out of 100 patients which you see, one clinic may say only 3 have OSA, but the other clinic will say almost all of my patients have OSA. Why does this happen? This happens because you have different study populations. You use different diagnostic criteria for defining sleep apnea. And once the most common factors remain, you don't have a suspicion of sleep apnea. Unless you have a suspicion, you won't ask it. Unless you won't ask it, you won't test it. And unless you won't test it, it won't be documented as a prevalence. So why does OSA happens in COPD? Because 4 factors are predominantly there. Once patient have cor pulmonale, there is a fluid shift while they are supine. Smoking itself leads to upper airway inflammation and upper airway relaxation. There is reduced ventilatory drive as we have seen in the pathogenesis. And again, chronic patients who are on chronic oral steroid use, they have increase in neck size, decreasing the precritical pressure. Why does this happens in ILD? The pathophysiology is entirely different. In ILD, we have reduced lung volumes. That means the FRC is low, which predisposes again to airway collapse by being close to closing capacity. There is heightened chemoresponsiveness because of overventilation, and there is sustained hypoxemia, which as a part of ILD is there. This leads to increased chemoresponsiveness and hence ventilatory instability. So a fall of 3 or 4 units of PO2 in COPD may not have a hyperventilatory response, but in ILD, a fall of 3 or 4 PO2 will have a very high ventilatory response. What happens in bronchial asthma? The pathophysiology actually changes. It begins from the nose. So you may have concomitant allergic rhinitis, which may lead to nasal obstruction. Your patient may be obese and has GARD, which may lead to edema, inflammation, and spasm of the upper way. And again, asthma is a systemic disease. The inflammation from the central as well as peripheral chemoreceptors may elevate the hypoxic ventilatory drive and again brings the breathing instability. So COPD, some may say there is a promoting factor for OSA, the other will say there is protective factor for OSA. That's why all COPDs do not develop OSAs, and we have a wide range of prevalence depending if it is promotive or if the COPD component is protected. Now the question comes, what are the diagnostic issues in suspecting OSA in chronic respiratory disease? So the question comes, should I test all of my COPDs? They are all thin, lean. Why should I test them for OSA? So thin and lean doesn't mean patient will not have an obstructive sleep apnea. Where do you suspect if patient has started developing daytime hypoxemia? So it is not that patient is COPD and developing hypoxemia. I will just start escalating pharmacotherapy and not consider OSA as one of the causes. When you have hypercapnia during wakefulness, again, a patient of COPD who has hypercapnia, we need to see whether there is a coexisting sleep apnea or not in these patients before labeling this hypercapnia as because of severe COPD. If patient has pulmonary or systemic hypertension or patient has coexisting heart failure. So what do the guidelines recommend? Do all patients need to be screened for OSA? So the guidelines recommend patient with chronic, stable, hypercapnic COPD should undergo OSA screening before initiation of long-term NIV. So how do I do it? It's very simple. In your OPD, you have a stop bank questionnaire. If the score is 3 or more, it is very sensitive and it is more useful than using just the Epworth Sleepiness Scale. If your score is positive, it should be followed by a PSG, ideally in a lab. A patient with chronic respiratory disease is not the one who is meant for level 3 or level 4 sleep study. They are meant to be level 1. I'll explain you in future slides why. What are the issues when you do polysomnography in patients with your chronic respiratory disease? You will observe there are more number of desaturation events than a patient without a chronic respiratory disease. Why does this happen? Again, this happens because patients are on a steeper curve of oxygen dissociation curve. So the PO2 falls rapidly. Once it falls rapidly, patient awakes. Patient awakes, washes out some bit of CO2, goes back to sleep. CO2 rises and again oxygen falls. So that is why we see a lot of sawtooth pattern on nocturnal oximetry, which is again one of the screening device. If you see a lot of sawtooth pattern, lot of SO2 fluctuations overnight in a COPD case, you suspect sleep apnea. Next question comes duration of event. So if you are waking up very quickly, your events will be shorter duration. So many of your events may not even meet the definition of 10 seconds of for defined as apnea or hypopnea. They may be 8 seconds, 9 seconds, but their number will be more. So this is a problem. When you see lot of events which are there and many of the events which are just not meeting the definition, you suspect a sleep apnea in patients with respiratory disease. Other term is central hypopneas and apneas. As we have seen in pathophysiology, you see a lot of hypopneas and apneas in these patients which are central in nature because of reduced ventilatory drive. How do we see it? Well, you need to do a esophageal manometry, and we were lucky to do one of these studies at our center where Dr. Viswesh, me and Dr. Devashish was one of the authors in the paper, where we found them that they have lot of central hypopneas and not obstructive hypopneas or apneas. So that the point where your CPAP is not going to work because they are not, they are central in nature. And fourth most common thing is hypoventilation. So what is hypoventilation? Hypoventilation is your CO2 rises during sleep by 10 mmHg more than the baseline when you measure it by transcutaneous CO2 monitoring. If you do not have a transcutaneous CO2 monitoring, you can see rise in end-tidal CO2, but the end-tidal CO2 cannot be used during a therapeutic portion. It is only during a diagnostic. The other simpler thing can be done is you can have an arterial blood gas before the sleep and as soon as the patient wakes up in the morning. So if you find a 10 mmHg rise of PCO2, we call it as hypoventilation. So this is one of the graphs from from our case of COPD, where we see lot of hypopneas, lot of obstructive apneas, and lot of arousals during this epoch. You can see patients desaturating, falling saturation 97, 89, even to 74 and 91. So these are all events. You see lot of fluctuations in the pulse rate, 74, 89. So there is a pulse transit drop also, which you can see. So all these features are suggestive of patient is suspecting of obstructive sleep apnea. Now comes the therapeutic portion. Therapeutic portion begins with, always it begins with a CPAP. It is not that patient is COPD, I'll start with the BiPAP. So always it begins with a CPAP. And as we kept increasing CPAP, at 11 CPAP, we can see all events have been eliminated. There's not even the saturation has been maintained, and there is no less variability in the pulse. So this is from one of the other cases where we have severe COPD. Patient came us with respiratory failure. We did a sleep study, and we can see lot of obstructive events, lot of hypopneas, and despite giving the therapy, they have not completely been eliminated. If you see, only the obstructive events have been eliminated, not the hypopneas have not been eliminated. So for completing the study, for completing the diagnostic portion and the therapeutic portion and giving the therapy, we need to eliminate hypopneas also. It is not just the obstructive apneas. So when we saw the end-tidal CO2 in this patient, so the end-tidal CO2 and the transcutaneous CO2 was risen from 51 to 67. That is, rise was more than 10 mmHg. That means this patient is, after the obstructive events have been corrected, is now into the hypoventilation phase. So hypoventilation phase means there is a less respiratory drive and less responsiveness to increase CO2. Patient is not able to increase the drive to wash out that CO2. So what we have to do at this stage, once the CO2 start rising, we give it into the two pressure therapy, the IPAP and the EPAP therapy to the patient. So that is the time where you start giving BiPAP therapy to the patient and start titrating it further. So first we begin with CPAP. If CPAP eliminates everything, we continue with CPAP. If CPAP pressures are very high, that is they go more than 10, we start splitting them. But if patient develops hypoventilation, we need to give something as a BiPAP with a backup respiratory rate. So this is a very busy slide. It has been a review which has been published by Dr. Suri sir. And to make it simplified, very simple. Once you document a daytime hypercapnia, you do a stop bank scoring. If stop bank scoring is positive, you do a polysomnography with a transcutaneous CO2. You see whether patient is OSA, severe or non-severe. Once he is severe, you do a CPAP titration. Once he is non-severe, he is probably a sleep-related hypoventilation and not pure OSA. This is where end-tidal CO2 helps you. Just the end-tidal CO2 is rising and not your obstruct events are not increasing. These patient needs a specific high-intensity NIV therapy, which is different from a routine BiPAP therapy. It is very high pressure support and very high pressure therapy. If your stop bang is, if you do not have hypercapnia, but stop bang is 3, again you go for a polysomnography. You see whether there is a syndrome with predominant OSA and you give CPAP therapy. If CPAP failure, you give BPAP therapy. But if patient does not have hypercapnia, patient does have a stop bang, but has pulmonary hypertension, diurnal hypoxemia or nocturnal hypoxemia, you think OSA is unlikely and you look for other causes of sleep apnea. So this is how we suspect and this is how we go ahead and treat it. So again, to reiterate, this is the most important thing. If your patient has a baseline low SO2, you need to be very much considerable in this patient before giving them oxygen therapy or before giving them BiPAP therapy. You need to do a polysomnography to see what is happening in sleep. Unless you treat sleep, you will not be able to treat patient in the awake state. This is very clear from the literature. This is very clear from the clinical practice. You need to treat what happens during the sleep in these patients. I'm thankful for your kind attention. And if any queries are there, you can always drop me an email. I'll be more than happy to answer it.
Yeah.
Vishwesh, that's all from my side.
Thank you, Dr. Nitesh sir, for an excellent overview on sleep disorders and chronic respiratory diseases. I think you covered most of the aspects of it, especially the concept of hypoventilation, and not all COPD with OSA patient requires a BiPAP. So that is also something which has to be conveyed to everybody who are listening to this lecture. Anyway, we have a question and answer session. I think we'll get a lot of these doubts cleared. So without wasting much of the time, we move on to our next speaker, who is again a very close friend of mine and very good senior, and who has been in long association with us for much of the work with related to sleep. So it is none other than Dr. Indranil Halder. He is a professor and HOD in the Department of Pulmonary Medicine, COM and JNM Hospital, West Bengal University of Health Sciences, Kalyani. And I don't think he needs much of an introduction. He has been a reputed member in many of the organizations related to the sleep medicine, and he is also an invited speaker in different national conferences, and he has got numerous publications in national and international index journals, and has also contributed to a lot of chapters in the book of respiratory medicine. And he is also the technical expert group for chronic respiratory diseases in the Ministry of Health and Family Welfare, Government of India. So today we have Dr. Indranil Halder sir to present his topic on pediatric sleep apnea, the approach and management. Over to you, sir.
So thank you, Visweswaran. Thanks, Amita, for his and thanks, Raja, who is the secretary of the ICS. I should onset thanks the ICS for giving me this opportunity. And sorry, my screen is not being shared. I don't know. Let me see. I hope it is visible right now.
Yes, sir, it's visible.
Okay. So I'll be moving on to pediatric sleep apnea, the approach and management. In fact, if you see pediatric sleep apnea, the spectrum of pediatric sleep disordered breathing is large. Primary snoring is there. Upper airway resistance syndrome, where there is increased respiratory effort, arousal, and normal oxygenation is there. Obstructive hypoventilation is one component, where there is partial upper airway obstruction causing hypercapnia, hypoxemia without discrete apnea. But what is more important and what is common is the obstructive sleep apnea, where there is desaturation and sleep fragmentation. There is mixed sleep apnea and the central sleep apnea with the absent respiratory effort due to CNS control instability, which is less common in the healthy children. So today my topic will be more concentrating on the obstructive sleep apnea, which is more common, and you can definitely see this kind of pediatric child who snores, and you can just observe the apnea and the irritability of the child with the sleep fragmentation, or this kind just who is sleeping just sitting down on his bed, who cannot sleep on lying down. So with this, it is a common condition in childhood and can result in severe complication if it is left untreated. In 2002, the American Academy of Pediatrics published a practical guidelines for the diagnosis and management, which has then been revised. And if you see, the interest has been growing in pediatric sleep apnea, and which can be seen from the number of publications from 2013 to 2022. And the prevalence range anywhere between 1.2 to 5.7%. And you can see the publications starting from 2013 and how it is increasing in number. So just an idea about the normal sleep pattern in the pediatric age group. So in the beginning, where you have more of REM sleep, and then the REM sleep decreases, where in adulthood only 20% of the sleep is REM. And then if you go to that, if we define obstructive sleep apnea syndrome in children, it can be defined as a disorder of the breathing during sleep, which is characterized by prolonged partial upper airway obstruction and or intermediate complete obstruction, which disrupts the normal ventilation during sleep and normal sleep pattern. So the pathophysiology of airway obstruction in the pediatric group is somewhat different from that of the adult. So whereas in children, the largest group of obstructive sleep apnea is because of adenotonsillar hypertrophy. The second group may be because of the prevalence of obesity. And there are a third group where there is multifactorial. But there are congenital anomalies which contributes to this obstructive sleep apnea, which may be achondroplasia, craniofacial abnormalities, narrow pharyngeal airways, which predispose them to this obstruction. Another very important group is children with Down syndrome, where there is a combination of abnormally narrow upper airways and reduced pharyngeal muscles. And it has been seen that about 2/3 of the children with Down syndrome have some form of sleep disordered breathing. So adenotonsillar hypertrophy, obesity, cerebral palsy, Down syndrome, craniofacial abnormality, muscular dystrophy, and achondroplasia, mucopolysaccharidosis, Prader-Willi syndrome, and some other syndrome all contributes to the pathophysiology or the syndromic association of OSA. So why is it important that we identify obstructive sleep apnea in the children because of the potential consequences that it happens. For example, in growth, there is severe OSA can be associated with failure to thrive. The poor growth in part is due to increased energy that has been spent necessary to meet the demands of an elevated work of breathing during the sleep. The cardiopulmonary is also huge because untreated severe OSA leads to cardiovascular effect, which includes the right and the left ventricle dysfunction, systemic hypertension, as well as endothelial dysfunctions. There is also an important impact on the neurobehavioral and cardiovascular consequences because of the sleep fragmentation from repeated arousal. Primary snoring alone has a link to the slow wave activity changes in the EEG, which reflects impaired restorative sleep function. OSA impact on sleep and the arousal pattern during the preschool years when children are in the critical period of the neurodevelopment leads to neurodevelopmental disorders, and increased level of the urinary catecholamine suggests some of the cardiovascular events that occurs with OSA. So what should be the diagnostic workup? So it is important that caregivers of all children should be asked about the snoring during routine healthcare visit. And if you see a child who snores more than 3 nights per week, or has a loud snoring, or has pause in breathing, should undergo a full evaluation in order to diagnose with obstructive sleep apnea. So there are risk factors and there are symptoms that may be associated, for example, hyperactivity, excessive daytime sleepiness, or even learning problem and behavioral problem in children should give us a clue that we should be evaluating them for OSA. So there are a few questionnaires in pediatric, but they are not that, they don't lack sensitivity and specificity. Some of them are the sleep habits in infant, brief infant sleep questionnaires, more than 1 year, the children's sleep habit questionnaire or the pediatric sleep questionnaires, or if you are assessing the daytime sleepiness, the pediatric daytime sleepiness scale or the Cleveland adolescent sleepiness questionnaire. But again, all of these are only have increasing in the chance of the pretest probability, and we have to screen those for OSA. They lack sensitivity and specificity to this extent. So they are used as a screening tool and are insufficient to make a diagnosis and put the patient on the treatment line. So the evaluation, it should be a focused sleep history. The physical examination should be detailed, and ultimately polysomnography has to be done and may have to be referred to a sleep specialist or an otolaryngology for further evaluation and possible treatment. So again, from the history, frequent snoring, labored breathing, sleep enuresis, sleeping in seated position, with the picture I have shown, or on examination, if you see overweight or even underweight because of the growth retardation, if you see an adenoid facies, micrognathia or retrognathia, high arch palate, hypertension in children, we should be putting the patient for a screening test or for the OSA. So one of the key statements from the American Academy of Pediatrics, if a child or adolescent snores on a regular basis or has any of the complaints of finding of OSAs, they should be obtained in polysomnography and referred to a specialist or an otolaryngologist for an extensive evaluation. And if you see the new American Academy of Sleep Medicine scoring manual is the first to be clearly delineated pediatric scoring system, which is different from the adult. And all the leads that are to be there in a level 1 study has to be there. And again, the scoring is also very important, where in an adult, it is different in the pediatrics, where an apnea is defined as a decrease in flow of more than 90% for, this is very important, for 2 breaths or more, then we call it an apnea. Obstruction, when that is associated with ongoing respiratory effort. Hypopnea, 30% reduction for 2 breaths, plus 3%, more than 3% saturation, desaturation on the with or EEG arousal. And in central apnea, apnea with absent respiratory effort, plus more than 3% saturation on or EEG arousal. So there are gradation, severity gradation. So if the apnea hypopnea index is more than 1, above 12 years, we call OSA. and AHI greater than 5 in adolescent, the cutoff value is generally used. There are oxygen desaturation, change in nadir oxygen or maximum end-tidal carbon dioxide, increase end-tidal carbon dioxide, all these are there. But the AHI is one of that which is there. In a normal child, it is less than 1, mild if it is 1 to 5, moderate more than 5 but less than 10, anything above 10 is severe OSA, which is different from the adult. In the right panel, I have shown what the adult values are. So if polysomnography is not available in a resource limited setting, then the clinician may order alternative diagnostic tests like nocturnal video recording, nocturnal oximetry, daytime nap polysomnography, or ambulatory polysomnography. All of these alternative tests has a low negative predictive value, including that a negative result is not sufficient to exclude OSA, and this test should not be used in routine practice. So the gold standard of diagnosing OSA in the pediatric patient is an in-lab attended polysomnography, the level 1, due to its accuracy in diagnosing respiratory diseases and disorders and the sleep architectural changes. So alternative, out of the center sleep testing or home sleep testing, portable monitor, ambulatory device, actigraphy, cardiopulmonary coupling, all are there. It is not recommended for diagnosis of OSA in children, as explained in most of the position paper from the American Academy of Sleep Medicine. But again, there are systematic reviews that was done in 2021, which analyzed the diagnostic performance of the portable monitor, which are very commonly used in the adult population, compared with the PSG for the diagnosis of pediatric OSA, and where 20 studies were analyzed, and they have shown that the AHI measured by the PSG compared to different portable monitor showed a pool sensitivity of 74% and a specificity of 90%. So the studies show the potentiality of the portable PM for screening pediatric OSA and may provide an alternative method in resource limited setting. So other dynamic MRI, respiratory induced plethysmography are there, but again, these are in limited settings. Now coming to the management and what are the therapeutic options. So the important option in pediatric OSA is adenotonsillectomy. In otherwise healthy subjects who have OSA and adenotonsillar hypertrophy, a adenotonsillectomy is indicated. The decision should be made collectively with the family, and it may also be the initial therapy for children with other contributors to OSA such as obesity or other comorbidities. But again, a watchful waiting up to 6 months may be tried in mild to moderate OSA, which has been confirmed by polysomnography. So that is less than 10, watchful waiting with supportive care in a reasonable alternative. And this has been seen and this has been shown in the childhood adenotonsillectomy trial, where it has been as an acceptable outcome in mild to moderate OSA in the pediatric age group. But the child should be reevaluated clinically with 6 months or sooner if the symptoms worsen. Coming to the main therapy, the positive airway pressure therapy, which is the main therapy for adult. In patients with minimal adenotonsillar tissue or a strong preference for a non-surgical approach, the positive airway pressure therapy is an alternative to the adenotonsillectomy. It may also be appropriate to stabilize children who are having severe OSA prior to the surgery or other surgical procedures, or for children with persistent OSA despite an adenotonsillectomy operations. There are other therapeutic options like rapid mandibular expansion, mandibular advancement device, or anti-inflammatory therapy or steroids even. But again, these are not that appropriate, and adenotonsillectomy is very effective in treating OSAs in pediatric age group, and adenotonsillectomy or tonsillectomy alone may not be sufficient because of the residual lymphoid tissue, which may contribute to persistent obstruction. And in otherwise healthy children with adenotonsillar hypertrophy, adenotonsillectomy is associated with the improvement in the symptoms and the sequelae of OSAs. Postoperative polysomnography typically shows a major decrease in the number of obstructive events. So if there is a residual OSA, that may be treated with PAP therapy. Although obese children may have less satisfactory result, many will be adequately getting relief with the adenotonsillectomy. I'll just highlight some of the dilemma or current trends that are there. So the question arises, is the primary indication for tonsillectomy sleep disordered breathing? In many of the cases, a diagnosis of sleep disordered breathing is based on history and physical examination. Because of the resource limited and lack of pediatric sleep study, and most pediatric otolaryngologists proceed to go for an adenotonsillectomy without a diagnosis of OSA or a sleep study. They just see the adenoids, they see the enlarged adenoid, don't do a sleep study, but just go for an adenotonsillectomy in pediatric age group who snores. So does AHI tell the complete story in the pediatric age group? No. And there are studies which have demonstrated little or no relationship between the AHI and the baseline neurobehavioral morbidity or response to therapy along with children with OSA. And this has been seen. So what is important is that we clinician and also the researcher pay more attention to the PSG, ignoring the real feeling of the children. Severity of OSA measured by the obstructive AHI score does not correlate with the quality of life of children with OSA. Consequently, the AHI score does not fully reflect the OSA's impact on the child health. It is high time to pay more attention to the quality of life instruments such as the OSA 18 questionnaire to help determine the most appropriate therapy in these children. So I should conclude saying pediatric OSAs has been commonly overlooked. It is underdiagnosed by both the parents and the clinician. It is different. The pediatricians are not miniature adults. They should not, they should be treated, or otherwise they may have serious morbidities, most of which, if they treated, will be reversible by early detection. Although the clinical parameters in the pediatric PSG field are still evolving, it is the best and the gold standard diagnostic tool. The surgery, adenotonsillectomy, remains the primary surgery for most severe cases, whereas positive airway pressure and pharmacotherapy are a good alternative options where surgery is not possible in the residual ones. Close follow-up. And what is important is a multidisciplinary intervention with a sleep specialist, pediatrician, and an otolaryngologist is needed to restore functional activity in the sleep disordered breathing. So thank you, and over to you, Visweswaran.
Thank you, Dr. Indranil sir, for an excellent overview. I think one point, if you have to take from your lecture, is children are not miniature adults. So everything is different in them. And that is why we are today discussing about pediatric sleep disorders. So now we have heard the talks from both excellent speakers. Now we move on to the panel discussion. So today, to join with us in the panel discussion, we have esteemed panelists. We have Dr. Harjit Dumra, who comes with vast experience in critical care, pulmonary medicine, and definitely sleep is also one of his forte. And along with that, we have Dr. Harjit Dumra is a consultant transplant pulmonologist, sleep medicine, and critical care specialist at KD Hospital, Ahmedabad in Gujarat. And he is the director of the Spurs Chest Disease Center, a long friend of mine and a great orator. And he has got numerous publications in index journals. And I don't think he needs any further introduction because every one of us here knows him personally as well. So we move on to our next panelist. Our next panelist is again a close friend. I think today the web meet is all about friends interacting with each other to get the best of sleep disorder update. So again, we have Dr. Sameer Bansal here. He is a senior consultant, pulmonary critical care and interventional pulmonologist at Apollo Hospitals, Bangalore, and he is a senior consultant and clinical head at Vayu Chest and Sleep Specialist. More than 45 publications, and the person with a lot of interest in research. And recently, they conducted one of the state-of-art interventional pulmonology program at Bangalore as well. Welcome, Dr. Sameer, and last but not the least, Dr. Harshini Errabelli. She is again a very good friend, and she is also from the same city of Hyderabad, and she has exclusively focused herself on developing high-end sleep technology centers, and currently she is the founder of the Sleep Therapeutics, a state-of-art sleep center in the city of Hyderabad. And she has been an AI advisor for the healthcare in the Watson University and a faculty in the CHEST, NAPCON, and multiple national and international programs. And she is awarded as one of the top 10 pulmonologists in 2023 by former Health Minister Telangana. And she is also a member in various national and international societies. So without wasting much of the time, we move on to the questions of the panel discussion. My first question is to Dr. Harjit. So what are the types of the sleep disorder breathing, sir? commonly seen in children, and what do you think is the most common of them you see in the child population?
Thank you, Vishwesh, for the question. I think Dr. Indranil Halder has elaborated most of the points, but just to sort of emphasize some of them as take-home points for the attendees. By and large, the spectrum of sleep disordered breathing pretty much remains the same in pediatric patients as the adult patients, but there are certain subtle differences. So we can classify most of these patterns into obstructive or central. One thing which needs to be emphasized for pediatric patients is that most often the obstructive events are in a continuum. So as Dr. Halder mentioned, that you will have quite a few patients with primary snoring, some of them with upper airway resistance syndrome, some with obstructive hyperventilation, and last but not the least, patients with full-blown obstructive sleep apnea. Now, many of the children would start with just habitual snoring, but over a period of time will graduate to obstructive sleep apnea, and you might pick up these patients at some point of the continuum. So it's not necessary that these patients will stay at one point of time. They will evolve from one to the other. Primary snoring, although is the commonest, but the one which is most clinically significant is obstructive sleep apnea. Just a few points about some of these obstructive events which happen in sleep for pediatric patients. As far as obstructive hypoventilation is concerned, which is one of the lesser common modalities, it's primarily seen with patients with adenotonsillar hypertrophy, sometimes with craniofacial abnormalities like micronathia, retronathia. Some of the children, particularly with muscular dystrophy, say Duchenne's or spinal muscular atrophy, particularly neuromuscular weakness presents with sleep apnea. Obesity is not uncommon in our country, and some of the congenital variants where you have extensive obesity is Prader-Willi syndrome, and these patients also will present with sleep apnea. And presence of obesity, craniofacial abnormalities, neuromuscular weakness increases the suspicion of sleep apnea in the pediatric patients. Central sleep apneas are not as common as obstructive events in children, but they can be seen, and particularly in patients with neurologic or genetic conditions. Sometimes you might have premature kids who will have a lot of central sleep events, and these are usually children who have very low body weight. And then there is the famous Ondine's curse, which is an autonomic dysfunction of respiratory control, and that at least I haven't seen in my practice. So the commonest will be primary snoring, but the most clinically relevant will be sleep apneas. Some few pearls, which I would say, or some relevant points as far as when we talk about pediatric sleep disorders. One I already mentioned was a continuum. Secondly, do not focus a lot on just excessive daytime sleepiness when we talk about kids, because we need to focus on other symptoms which might be equally relevant. So these could be hyperactivity, aggression, irritability, children with attention deficit. These are also certain presentations which can possibly sort of indicate a presence of sleep apnea in children. Nocturnal enuresis, which was not there initially, but start secondarily, also would draw your attention to the presence of sleep disordered breathing. And last but not the least, particularly patients with obesity, Down syndrome, cerebral palsy, neuromuscular disorders, and craniofacial abnormalities should be pinpointed specifically to rule out sleep disorders.
Yeah. Perfect,
So,
Dr.
you have
Harjit.
summarized my presentation excellently. Absolutely.
Thanks.
Yeah, I think almost it was a summary of the
I
entire.
have really, the summary of all things has been done, Harjit. Good job.
True. And for the audience here, if at all you want to take few important points with the extensive explanation given by Dr. Harjit Dumra, excessive daytime sleepiness might not be the only symptom with which the kid is going to present. Always look for nocturnal enuresis, and suddenly if a child who was performing well in school becomes less in academic activities or has an attention deficit hyperkinetic disorder, then possibly these may indicate the presence of an underlying obstructive sleep apnea. Now, moving on to Dr. Samir. So, we have heard in length about the symptoms and the types of disorders which are associated with the pediatric OSA. But what are the causes? I think Dr. Harjit had already touched upon few of the genetic syndromes and other things. So, if at all, for the interest of the audience, you want to say what are the specific causes you look for a pediatric OSA, and how do you really diagnose this pediatric OSA?
So I think, again, this is just to emphasize on what has already been spoken. I think Dr. Halder has spoken a lot about it, and Dr. Dumra just gave a nice summary of the entire thing. But in general, I think it is important to note that yes, the classification is very different. It's not what we apply to the adults, which is based on the AHI criteria of 5 to 15, 15 to 30, and more than that. For children, it's quite different. It's 1 to 5, 5 to 10, and more than 10, which is the mild, moderate, and the severe. Again, the causes also, yes, of course, OSA is one of the most common and most relevant, disorders that we do see. Important is, the major common cause over here is the adenoid hypertrophy, adenotonsillar hypertrophy, which is one of the most common causes. In specificity, we also look for, yes, allergic rhinitis. A lot of patients do present to us with that. Meanwhile, in children, there are all these spectrum of genetic disorders, Prader-Willi, Down syndrome. All of these patients can present with it. A lot of muscular dystrophies, which have genetic origins. They also, because of the upper airway collapsibility, which is too much in these patients, they do present. And finally, a lot of craniofacial abnormalities, apart from all of these, such as even the cleft lips and cleft palates, can also lead to all this. Plus, you have the micronathias and retronathias, which do cause certain conditions, again, which is not very commonly talked about, is behavioral disorders also, when the children actually abduct their vocal cords very tightly. Now, these are also certain things which, certain conditions which can actually lead to obstructive sleep apnea, in which case, again, maybe the conventional CPAPs and all also do not really help. And in which most of the times, some behavioral therapy is what is required. So these are a few of the common and specific causes. I won't dwell too much onto it since we've already discussed a lot about the causes already.
Yeah, perfect, Dr. Samir. The important thing for all the audience here is adenoid hypertrophy, something that is often overlooked, especially when you have a kid who has got a stuffy nose, breathes through his mouth, and has got snoring in the night and gets frequent ear blocks. Along with you're suspecting an obstructive sleep apnea, then one thing you should never forget is the obstructive sleep apnea. And always you need to look into the anatomical aspects. Unlike the adult, where we just focus on the obesity, anatomical aspects like maxilla and mandibular derangements can also lead to a lot of these cases of pediatric OSA. So now moving on to Dr. Harshini. So we heard a little from both Dr. Samir and Dr. Harjit Dumra. So what are the signs and the symptoms of a pediatric OSA?
So I think this will be the third time because both the doctors summarize very well. So obviously loud snoring is one thing, but at the same time, if we observe their face, most of the times they'll have adenoid faces and they'll have mouth opening, mouth breathing, and excessive nocturia. I think it should not be forgotten. So apart from the nighttime routine obstructive sleep apnea symptoms like any witnessed apnea spells or gasping, choking especially, so disturbed sleep is always seen, and night terrors or parasomnias also can be seen. Along with these nighttime symptoms, I think daytime signs and symptoms should not be ignored. Their school performance will be poor, their growth will be poor, and they'll have hyperactivity. Sometimes they may not perform as per their level, but at the same time, hyperactivity might be there. And many times this hyperactivity is actually these days being misdiagnosed as ADHD. So I think we should look into their sleep patterns and sleep apnea before actually diagnosing them as ADHD. And the most red flag signs which are suggestive of sleep apnea is habitual snoring, which is more than 3 nights per week, or observed breath pauses, excessive bedwetting. Even after 7 years of age, we see bedwetting. And also, of course, enlarged tonsils, adenoids, and all this.
Yeah, thank you, Dr. Harshini. And now to Dr. Nitesh, sir. So Dr. Indranil, sir, had said in his presentation as well, but for the interest of the audience, how do we diagnose pediatric OSA and how do we grade the severity? I think Dr. Samir also touched upon it a little.
Right. So pediatric OSA, first of all, should be diagnosed by level 1 polysomnography. There is no indication of doing level 3, 4, or 2 in a pediatric suspected patients. Secondly, the lab must be well equipped with the pediatric sensors. You need a different pediatric pulse oximetry for so that it fits into the small child's finger. The adult oximetry does not fit well, hence we may miss a lot of events. So this is what the basic preparation should be. And doing a level 1 polysomnography, the whole night polysomnography should be done. We don't usually do split night polysomnography in children. We do a whole night polysomnography, and diagnostic events are recorded as severity. Even a single event means child has OSA. More than 1 to 5 is then taken as mild, 5 to 10 is moderate, and 10 AHI index of more than 10 is a severe OSA. So even a single documented event labels the child as having OSA, and we must try to correct the cause for the same.
Yeah, for the audience here, even an AHI of 1 is abnormal in a pediatric, unlike the adult, where we take it is more than 5. So I think we have already heard about this answers for this question, but still to Dr. Indranil Halder sir, so what is the difference between the adult and the pediatric OSA? If you have to give 3 differences between the adult and the pediatric, just 3 solid points for the audience.
So first of all, I should be telling the bottom line that OSA in children is more of a structural and a developmental issue. So affecting growth and the behavioral problem, with adenotonsillar hypertrophy being the prime culprit. Whereas in an adult, you see it is more of a chronic metabolic, also an anatomical problem linked to obesity. There is cardiovascular risk, and there are other long-term problems. So if we go from the basic problem, that is the cause, adenotonsillar hypertrophy versus obesity, upper airway fat deposition, and if we go to the symptoms, again, restless sleep, unusual position in the sleep, hyperactivity is one of the symptoms in pediatric OSA, whereas in the adult it is excessive daytime sleepiness and loud snoring. So this may be pathophysiology, again airway collapse, often due to structural abnormality in the pediatric age group, whereas in more adults it is because maybe due to soft tissue or reduced upper airway dilated tone that has been seen. So this is the thing. Diagnostic has been discussed because here level 1 polysomnography is the absolutely indicated. Scoring is different. Management is surgery, whereas in adult it is with PAP therapy.
Yeah, excellent point, sir. So since you said surgery is one of the most important aspects of treatment of pediatric OSA, to Dr. Harjit, so what are the surgical options that are currently available for pediatric OSA? Apart from only adenoid tonsillectomy, is there anything like we have it in adults, uvulopalatopharyngoplasty? Like that, do you resort to it? Because with age, the changes may still occur in the structural development of the kid.
First, Vishwesh, I think the indications mentioned by Dr. Halder need to be emphasized that if you have just mild to moderate disease with symptoms, you can resort to surgery, but watchful observation is not a bad option, particularly as the children grow in height and weight. Sometimes these apneas can be abolished. Sometimes medical management with treatment of diseases like rhinosinusitis, adenoid hypertrophy, can show significant improvement. And so every patient should not be subjected to surgery. Those patients with severe OSA possibly are the ones which we should target for surgery. And adenoid tonsillectomy is the go-to surgery for most of these patients, provided obviously they have hypertrophied adenoids or tonsils. That is the one which we commonly advocate and commonly practice. There are certain modifications of this procedure where you can have a partial tonsillectomy or tonsillotomy and some pharyngoplasties, which can also be done, where sometimes you can broaden the upper airway by some surgeries, just focusing on the pharyngeal wall. Drug-induced sleep endoscopy is not so commonly practiced in pediatric patients, but if you basically believe that there are multiple etiologies contributing to sleep apnea and a surgery might not suffice, then to document multiple levels, you need to first go for a DIS, followed by a surgery which is multi-level. And amongst them, you can have uvulopalatopharyngoplasty, and you can have other surgeries as well. Now, options like hypoglossal nerve stimulation are still in its infancy, and I don't think we practice that in India. The last bit is cranial reconstructions for craniofacial abnormalities. sometimes like retronathia and stuff like that. And these are complex surgeries, and frankly speaking, the risk benefit should be calculated, because once a surgery is done, it cannot be reversed. So I suppose medical management should be given first priority in mild to moderate disease. For severe disease, needless delays can also affect the child's development. And so that is one area where you should sort of proceed for surgery as early as possible. I usually talk to my ENT colleagues to get a better know-how as to which would be the best candidates for a surgery, and only then I do proceed for surgeries.
Yeah, perfect, Dr. Harjit. I think the take-home point should be multidisciplinary discussion rather than just going for an upfront surgery for even a mild pediatric OSA, because recurrence rate can still be high because the child is still in the developmental phase. Now to Dr. Samir, what is the role of...
if I could just complete that
yes,
always after the surgery, we need to repeat a sleep study at 6 months, because many times the surgery has only corrected a part of the problem, and the child could still be harboring residual disease, which might be significant and might need addressing with other modalities.
Yeah. And I think that is something has to be emphasized to see whether the surgery was really efficient in overcoming this OSA or not. And to Dr. Samir, so we know that for adults, CPAP has almost become the gold standard. So what is the role of CPAP in pediatric OSA, and how do you really make a child understand and make them compliant on a CPAP? Because it's not going to be easy. Even in adults, we find it difficult for them to
That's absolutely true. In fact, as you rightly mentioned, number one, it has to be a multidisciplinary therapy always. Whether this child needs a surgery, because sometimes, yes, even though you can go for watchful wait, sometimes because these children are in developmental stage, all those nocturnal hypoxias and all can actually be quite detrimental. So yes, people or children who have persistent OSA, as Dr. Dumra just pointed out, after a surgery, say adenoid tonsillectomy, who are in general not good candidates for surgery, or who have OSA secondary to maybe some other abnormalities, craniofacial genetic syndromes, neuromuscular disorders. These are the children wherein you will consider a CPAP therapy possibly. The problem is, in fact, adherence and compliance. Because despite whatever, so the recent meta-analysis, I think, also suggested that it's best 40-60% or so. The issues are, of course, impacted by a lot of factors, which is the discomfort, mask fitting, pressure-related side effects, inconvenience, lack of parental support, and all of these things. Now, yes, there have been a lot of factors or studies have been done on how to improve the compliance. The most important is the caregiver or the parental support. That is without doubt. Okay, actively being involved in it. Okay, just maybe getting them acclimatized to the whole masking, putting them the mask maybe during daytime, just sitting down with them, making them realize the importance. And even respiratory therapist driven clinics, wherein you have a proper mask fit, the interface, choosing the right interface. In fact, a few companies have come up with pediatric masks, which have been there for quite some time, such as ResMed, Pixie. I think there may be others also. Sometimes it is also suggested, okay, the pediatric population may actually benefit more with the bi-level PAP rather than a continuous positive airway pressure. Again, because of the whole exhalation, inhalation dynamics, which are much better with a BiPAP in cases of children. And of course, any other specific barriers, if there is a pressure discomfort, mask leakage, anxiety, all of these are certain factors which I think once you address, it can really help in improving the overall compliance to the therapy.
Yeah, very excellent points, Dr. Samir. I think we need to educate more the parents than the kid when it comes to management of pediatric OSA. So to Dr. Harshini, we heard about surgery, we heard about mask CPAPs in pediatric OSA. Are there any other drugs or any new alterations in the PAP devices or surgical options that are available in pediatric OSA? Any updates?
Yeah, so certainly there are a few updates, like in surgery also, if you see, unlike the previous surgeries, now it's with more precision. And if you see tonsillectomy, it is partial or intracapsular tonsillectomy. So still they're preserving tonsillar capsule, which reduces pain and it reduces the bleeding risk. There's endoscopic adenoidectomy, so it's even more precise. There's lingual tonsillectomy. There's supraglottoplasty, where OSA, for those patients where OSA is linked with laryngomalacia. So everything after doing drug-induced sleep endoscopy, then a tailored surgery is done. So that is the advancement in surgery these days. And apart from that, there are few orthodontic interventions, like there is rapid maxillary expansion for those children to improve nasal airflow, and for children with craniofacial restrictions. And there are some mandibular advancement appliances. Of course, it's more common for adolescents, but I think there are few advances coming up for children as well. In myofunctional therapy also, there are targeted exercises, and there's expansion sphincter pharyngoplasty. Apart from this, in medical approach, intranasal steroids, mometasone, fluticasone, they are shown to have good improvement in children with mild OSA, and leukotriene receptor antagonists like montelukast, even mild to moderate, it is useful. Of course, again, combination therapy is better. And coming to PAP devices, it's that Z-breathe technique in Philips, or otherwise ramp techniques, and auto-titrating devices, heated humidification. So all these things which are inclusive in the newer devices are a good advancement when it is coming to PAP therapy. And also there's high flow nasal cannula, which can be used at night. So it is studied as a non-invasive alternative in selected pediatric OSA patients. And as previous speakers told, hypoglossal nerve stimulation still didn't come to India, but the trials have started in children. And along with all this, craniofacial surgeries for craniofacial anomalies is also being done. And of course, I think DICE is the main root thing which decides which kind of treatment a child should undergo.
Yeah, excellent points, Dr. Harshini. So I think we are still a long way to go when it comes to the pediatric OSA. But I think with AI coming, maybe we may get newer permutations and combinations in choosing possibly the right fit for a right patient. So, and to Dr. Nitesh, we have heard in length about pediatric OSA and its management. But when it comes to snoring or hyperkinetic disorders or whatever the symptoms related to the OSA of a pediatrics, there can still be some sort of a differential diagnosis. Maybe not all these sleep-related issues may point down to a OSA. So what are the differential diagnoses we need to consider when we are evaluating a patient with a pediatric OSA?
So differential diagnosis begins with the craniofacial abnormality, just a visual inspection of a child to see whether there is a prognathia, retrognathia. So that can be one there. Then allergic rhinitis, again, one of a common thing in children. This will lead to nasal obstruction, nasal hypertrophy, and again will have symptoms with difficulty in breathing and snoring, and child is keep sitting whole day and doesn't want to lie supine. Then other is your asthma. Again, it may have similar symptoms with sleep apnea. The nocturnal sleep disturbance is there, early awakening is there, poor school performance is going on. We may have few cases of laryngomalacia, which may go undetected earlier on, but then may develop as the child grows up and the larynx starts narrowing further. So this is these are the one of the DTs which we should consider in every child with suspected sleep apnea.
Yeah, excellent points. Because as in adults, never miss out on an underlying obstructive airway disorders in a pediatric OSA as well. So, and to Dr. Indranil, sir, so let's assume that you have a pediatric patient, you didn't treat them properly. In future, what are the expected complications you can see in them? Like what is going to be the detrimental consequences of an untreated pediatric OSA?
So, Visweswaran, I have already expressed in my talk, but again to just highlight. So probably the most important thing that is to be taken into account is the neurocognitive abnormality that we see in the pediatric. For example, the learning defect, behavioral problems, the developmental delay, and they may be again failure to thrive. The cardiovascular complications are also there because of the inflammatory markers that are there. And for example, pulmonary hypertension may develop, metabolic, not only growth retardation, growth failure, but also obesity and metabolic dysfunctions. There may be psychosocial, which is important. For example, depression, enuresis, memory impairment that we already discussed, and some of the respiratory complications if left untreated, risk of say other pulmonary complication because of the pulmonary hypertension that they ultimately develop later on. So this may be in short that what are the risks of untreated and if we are living pediatric OSA in.
Yeah, perfect. So to Dr. Harjit, we have heard in length about the pediatric OSA. So just like in adults, like what are the parasomnias that can occur in a pediatric sleep disorder?
So one thing about parasomnias in children is that many times parents might not access doctors for obstructive sleep apnea related symptoms like snoring or breathing with an open mouth. But it is definite that children with parasomnias, the parents are definitely going to access physicians or even pediatricians because they cause a lot of alarm to parents. So just to sort of give a simple explanation of parasomnias, these are unusual behaviors, maybe movements, sometimes emotions or experiences that might happen when the person is falling asleep or just waking up for sleep or during sleep. What needs to be emphasized is that most of the times parasomnias in children are benign. And as children grow older, they will outgrow them. And many times they run in families. So you might have a father telling the pediatrician that even I had similar problems when I was a child. Now, to sort of enumerate some of these parasomnias, most of them are in non-REM sleep. A few of them are in REM sleep. The major difference between these two is that the ones which happen in REM sleep don't always remembers, and sometimes that can have a problem down the line. So non-REM parasomnias, kids are more likely to forget. They might not sort of remember them down the line. So parasomnias in non-REM could be confusional arousals where, the child wakes up confused, sits up, mumbles and moans, and then goes back to sleep. Sometimes you can have sleepwalking where, the child might be eating or rearranging objects, walking. Sometimes there might be night terrors where the child gets up with intense tachycardia and sweating, sometimes with a loud scream. Maybe the eyes are also open, but the child is non-responsive. Compared to that, what we see in REM is something like nightmares, where the child will recall the dream in detail. And in fact, sometimes he may resist falling asleep the next night. Sometimes REM-related sleep behavioral disorders, where the child might enact the dreams, like maybe kicking, punching, because usually in REM sleep, you have loss of muscle paralysis, but in these parasomnias, the muscles still remain active. And other things like bruxism, sleepwalking are some of the other non-REM parasomnias. What one needs to possibly emphasize about parasomnias are, like I said, reassurance is mainly something which we should practice, and these are benign and self-limiting. Second thing is look at triggers for parasomnia. So if the child has fever or stress, or sometimes certain medications like antihistamines, sometimes if the child is on some sedatives like SSRIs, sometimes that can precipitate these events. We need to differentiate parasomnias from nocturnal seizures because that is something which comes up as a differential. And the way to differentiate it is that with parasomnias, you don't have post-ictal confusion, which you will have with seizures. Sometimes, even if there is an abnormal neurological examination, that will help you differentiate between parasomnias and neurological involvement. And the last bit is when parents talk to you about these parasomnias, you should counsel them that do not forcefully wake the child during a parasomnia or restrain the child just to avoid that. So you should guide them to at least some safer precautions and measures.
Yeah, perfect, Dr. Harjit. And I think one last question about pediatric OSA to Dr. Samir. So just can you enumerate what all the sleep related disorders you will observe in a patient with pediatrics? OSA, starting from OSA, just for the interest of the audience here. Dr. Samir, you are on mute.
Sorry. So I think as already pointed out, but all the previous speakers, so again, the most common being obstructive sleep apnea, snoring. There are, and the parasomnias, of course, which Dr. Dumra just beautifully summarized. So there's insomnia, which could be either difficulty initiating or maintaining sleep, restless leg syndrome. There's the periodic limb movement disorder, the central sleep apnea also, although if it is rare in cases of pediatric age group, but still it is there. Hypersomnolence, excessive daytime sleepiness, that is. A lot of these children also come up with upper airway resistance syndrome because of the adenoid hypertrophy or even allergic rhinitis, sinusitis. There's nocturnal enuresis as well, which again, involuntary urination in the night. And of course, other things which are related to their lifestyle, such as insufficient sleep syndrome, which could be there. So these are various disorders or sleep-related disorders, rather, that we see in pediatric age group.
Yeah, perfect, Dr. Samira, and along with it, possibly bruxism as well, which is quite common amongst children. So, to Dr. Harshini, now moving away from the pediatric OSA to the chronic respiratory disorders. So, we have heard about it in literature and everything. So, Oldosa. So, what does it really signify, and why it is important for a pulmonologist to know that?
So, Oldosa, I think it's very important for a pulmonologist to know, because it is a syndrome which is like the obstructive lung disease and obstructive sleep apnea syndrome. So the name itself, it signifies that there's a co-occurrence of any obstructive lung disease like COPD or asthma with sleep apnea. So what this will actually do is, there are two components in this. One is OSA and other one is a lung disease. So now when both are together, there is a bidirectional relationship. This obstructive lung disease is actually worsening sleep apnea and vice versa. So the exacerbation of both the symptoms are seen, and this increased severity, like when both the conditions are there, it becomes more severe. And even though we are optimizing the medications for obstructive lung conditions, when the sleep apnea component is not treated, or vice versa, the other symptoms are also not going to be treated well. So there's an increased risk of complications when compared to having either of the condition alone. Also with this, there's an increased mortality rate, and the implications for treatment would be an early detection and intervention for both sleep apnea and lung disease.
Yeah, perfect, Dr. Harshini. And Dr. Nitesh, so as a part of Oldosa, how does actually the sleep disorders impact a patient with particularly asthma? So is there any correlation between sleep and asthma, and how both mutually affect each other?
Right. So sleep and asthma again are bidirectional. A patient with OSA may develop asthma later on in life. A patient with asthma, especially severe asthma, who has been on long-term steroid therapy and has become obese, may develop sleep apnea later in life. So what they do is they worsen each other. A patient who is asthma and OSA will have nocturnal awakening, frequent nocturnal awakening. He will feel the nocturnal awakening is because of my asthma symptoms. He'll start taking a lot of sabas during it, which will again disturb his sleep, and patient will go into a vicious cycle of not being able to sleep and considering it as a non-response to his asthma therapy. So practically it may be seen as that asthma is worsening and patient may be move on to the next stage of the therapy. That's why even in evaluation of severe asthma, we need to rule out obstructive sleep apnea on prior before saying it is a severe asthma.
Yeah. And Dr. Indranil, so let's say I have a patient who is an asthmatic who doesn't have the typical body habitus of a OSA patient. He comes to you with medium build, with asthma. Still, I have a doubt of underlying OSA. So what are the predictive factors and what are the leading questions I should ask to them to identify the OSA in him?
So Nitish has explained it well. Again, to me, probably poor sleep quality, excessive daytime sleepiness, even in these asthma patients, or fragmented sleep, early morning awakening, as we see in OSA patient. When there is a persistent nocturnal asthma symptom, despite the optimum therapy, especially in severe asthma, we should be suspecting, which Dr. Gupta has already explained. Okay. And then we have to evaluate the patient. We have to assess asthma control in this patient, assess the nocturnal symptom. The sleep history has to be taken, and again, standardized questions may be there where we can ask them. And ultimately, the suspicion and polysomnography, if the nocturnal symptom persists, is the best thing that we can do. But again, what is important, these asthma patients may have allergic rhinitis. I personally feel that we have to inquire into that, treat the allergic rhinitis component, which is very important. And then again, they may be taking some medication, which may be also contributing to it. But ultimately, a sleep study, which is very essential, a level 1 sleep study is recommended for this asthma patient when we suspect this OSA in patients of asthma.
Yeah, excellent points, Dr. Indranil. And for the interest of the audience, you don't be aggressive in doing a sleep study when a patient is in an exacerbation. So that is where we often miss the link. So you need to get a good control of the asthma and then perform a sleep study to get possibly the best results. And to Dr. Harjit, so we heard about sleep affecting asthma and asthma affecting sleep. So more so for patients with COPD. So can you explain how both are interrelated, both at a physiological level and in the clinical perspective as well?
I think there is more data on COPD and sleep disorders as compared to asthma, or for that matter, even ILD. What one needs to emphasize here is that although we talk about obstructive sleep apnea and the overlap syndrome with sleep COPD, the commonest being overlap, but other sleep disorders can also come up in COPD. So it could be associated insomnia, it could be associated nocturnal hyperventilation, sometimes restless leg syndromes, even circadian rhythm disturbances are not uncommon with COPD. So there is a gamut of sleep disorders associated with COPD, and we only emphasize the overlap syndrome. Now, why does this coexistent sort of affect us a little more than an isolated COPD patients? Whenever there is OSA superimposed on COPD, obviously you will have more nocturnal desaturations. Maybe sometimes that can lead to more arrhythmias, because many times these patients have coexisting cardiac comorbidities. Obviously, you have more pulmonary hypertension and polycythemia. Association between sleep disorders and COPD doubles the cardiovascular risk. So more risks of strokes and anginas, heart failures, and acute coronary syndromes. Sleep disruption, what it does at a pathophysiological level, it increases the inflammatory load, which is already there. It's a systemic inflammatory response in COPD. And when you have an associated sleep disruption, this inflammatory process is magnified, and along with that, there is immune dysregulation, and all of that will lead to increasing frequency of exacerbations and including severity of exacerbations. Also, when you have poor sleep, you can have excessive daytime fatigue, depression, cognitive impairment, which affects the quality of a life of a patient with COPD. And obviously, we need to focus on theirs and where. And last but not the least, there is a significant decline in the quality of life if you have both these disorders happening together. So sleep disorder with COPD definitely is more cumbersome to manage than just a pure COPD. Sometimes what we can do is that how to pick up this sleep disorder. Sometimes treatment tends to pick it up. So sometimes giving PAP therapy, in fact, tends to diagnose that maybe there was an associated sleep disorders, because the patients might have a disproportionate, significant improvement, which you would not have seen just in a patient with COPD. So there you start thinking whether you have an associated sleep disorder.
Yeah, and another possible point is as you rightly said, frequent exacerbations, disproportionate pulmonary hypertension in a patient with an underlying COPD, and even best response to CPAP therapy. If a patient has an out of range improvement, then possibly, yes, you need to actively look for sleep disorders in these patients. So we heard about the impact of sleep on COPD and vice versa. But Dr. Samir, I think the pathophysiological mechanisms play a very important role when we speak about COPD and OSA, because that forms the basis on which you are going to initiate a PAP therapy. So how essentially, what really happens whenever there is an OSA with a COPD? Because we are not going to see a classical obese patient just like what we see in a classical OSA, whereas most of the COPD with the OSA tend to be emaciated, having a classical barrel-shaped chest. So what really happens?
Yeah, no, so exactly, I think beautiful points put up, because these are typically, patients, as we already know, and part of prognostic index is the BMI. Many people are actually sarcopenic. Further, what happens is, there are a lot of alterations in the respiratory mechanics already. There is an accentuated physiological hypoventilation when you have this. The dead space ventilation increases, or the overall dead space increases. There is a lot of muscle atrophy. The functional residual capacity is reduced. All of these actually during sleep will lead to further ventilation perfusion mismatch, and already a disadvantaged diaphragm. And further, during the sleep, when you have an OSA and increased dead space, it will definitely increase in ventilation perfusion mismatch. Now, this will lead to a profound nocturnal hypoxemia and, of course, hypercapnia as well. which will lead to daytime lower oxygen levels, as I think Dr. Nitesh also showed the ODC curve. So they are already on that steeper part of the curve. So, nighttime, they will just have very profound, and this will reflect in their daytime activities also. Now, another thing is all of this worsens actually in the REM sleep. Why? Because the accessory muscles which they use, REM sleep, again, because the accessory muscles are not in play at that point of time, which will further lead to a worsening during that part. And this leads to a lot of discomfort and leads to sleep fragmentation. So these people typically have increased arousal, sleep fragmentation. Finally, many of these people, why? Because they have a lot of mucus hypersecretion, which is there. They have problem with airway clearance and cough reflex. So they will have an increased upper airway resistance also. Furthermore, because of all the cardiovascular complications, because they're known to have a lot of, CVS issues, arrhythmias, there may be the right ventricular dysfunction, fluid overloads, that can actually lead to certain times, seeing central sleep apneas also in these patients, chain stroke, respiration, central sleep apneas, all of these are also seen. So all in all, it leads to sleep fragmentation. It leads to, further worsening. People are not able to do that, their rehabs as well. And data actually shows that 80% of all people with, overlap, they have pulmonary hypertension as compared to only 15% with maybe isolated OSA.
Yeah.
So these are certain important points which actually further increase the risk of acute respiratory failure in these patients.
True. Excellent points, Dr. Samir. So, but for the interest of the audience, severe nocturnal desaturations, prolonged periods of hypoventilation, especially REM-bound hypoventilation, and disproportionate pulmonary hypertension, and even there can be a mixed apneas. There can be a central along with an obstructive sleep apnea. So you need to know all these things because you're not going to see a classical OSA patient in a COPD. So to Dr. Harshini, we know that these patients are quite difficult to actually diagnose. First of all, you need to have a high index of suspicion, and then you're going to put them for a sleep study. Unfortunately, what happens is many a times they resort to level 3 study, and though it gives us a little bit of indication about the hypoxemia, it misses out on so many important values when it comes to proper titration with the PAP devices. So how do you really evaluate a patient with a coexistent obstructive sleep apnea and a COPD?
So first thing is when to suspect and how to evaluate. The main thing is nocturnal symptoms. So you should always ask the patient. So every COPD patient should be asked about their sleep, their snoring apnea spells, and all the sleep apnea symptoms in the first place. And second thing is daytime symptoms also. They might be having severe morning headaches. They might be having extreme fatigue, and they might be having cognitive changes, and all these things. In spite of optimal COPD management, there could be unexplained fatigue. And their exacerbation pattern also, it will be disproportionate dyspnea or hypoxemia as compared to spirometry values. So this frequent COPD exacerbations despite good inhaler compliance and disproportionate spirometry values, along with that this pulmonary hypertension or cor pulmonale which you see without any severe airflow limitation. So all these are important points in suspecting a patient from sleep apnea or a sleep disorder. And when we are evaluating also, first we need to go for the clinical screening. Like all the patients are not sleep apnea, like everyone who has COPD might not have sleep apnea. So we need to do a clinical questionnaire. As our speaker rightly said, the stop bang is better than Epworth Sleepiness Scale, and the stop bang questionnaire having more than or equal to 3. And we need to do some baseline daytime tests also to see for chronic hypercapnia or hypoxemia, nocturnal hypoxemias. As you just mentioned, we need to look for systemic hypertension development or pulmonary artery hypertension. And even in the polysomnography, I think it's very important for us to look for the transcutaneous CO2 or end-tidal CO2 values, if to see what is the CO2 levels along with hypoxemia. And continuous oxygen flow recording is very much required, and this should be a level 1 sleep study, because even after connecting NIV, like maybe CPAP or BiPAP, how the patient is actually responding. So it's very important to do a level 1 sleep study. So I think these are all the things which we should suspect and do during the study.
Yeah,
Also, there
perfect
are
points. Yeah. Please go ahead.
yeah. So also there are some criteria for oxygen escalations if they are dependent on oxygen levels also. And when they're dropping below 88% for more than 5 minutes, then we should see this, what is their baseline oxygen and how we should titrate the CPAP. Yeah.
Excellent points. So the important take-home message for all the audience here is, whenever you deal with any patient with any comorbidity and you suspect an obstructive sleep apnea, always the gold standard would be a level 1. Your level 3 can, if it comes positive, it can indicate, but if it comes negative with the high pretest probability, always resort to a level 1 polysomnography, and that remains the gold standard. So I think we'll move to Dr. Nitesh. You did touch upon in your lecture about the role of PAP in COPD patient. So this is very, very important question, because there is a concept of auto-PEEP. Like whenever you give a PAP device to a patient who is already having a hyperinflated lung, you may tend to cause more dynamic hyperinflation, leading to a worsening of his breathlessness. So how are you really going to optimize the PAP settings in a patient with a COPD? Should we always go for a BiPAP, or when will you actually choose a CPAP in a patient with a COPD? And beyond what pressure you don't want to give a continuous PAP, which can lead to dynamic hyperinflation and further worsening of his condition?
Right. So as I had shown you in the examples also, so CPAP is the first therapy which should be given to correct apneas and hypopneas in a patient. If we are able to correct it, achieve the optimal titration, we just keep it at CPAP. The question comes in COPD because of auto-PEEP, how much can we give? So we give about 12 to 13 of CPAP, and if it goes beyond it, we do it into a bi-level CPAP machine where we keep into a difference of 2 or 3 centimeters at the 2 different CPAP levels. However, if patient is not being able to correct and as patient is hypercapnic in daytime, we move to the BiPAP titration strategy where we begin at pressures of 8 and 4 with keeping a difference of 4 centimeter between the IPAP and EPAP, and accordingly we increase by 1 with seeing the number of events which are happening. So we just continue it, titrate it according to the protocol, and then see how long where we are able to correct the hypoventilation. The main thing in the titrating hypoventilation is you do not target normalization of CO2. You don't want that CO2 to come down from 62 to 52. Your whole target is that hypoventilation should not happen. So even if you are able to reduce by say 2 or 3 mmHg of CO2 in one night of sleep study, it is fine, because patient will be able to reduce CO2 only when it is chronically given therapy. In one night, you cannot get down to normal CO2 of 40. This is what we have to target. We just have to reduce the episodes which are occurring over the night.
Yeah. So the important practical points is, first you have to overcome the apneas. So that is where you start giving the CPAP. Sometimes you may even go till 8, 9, and if the patient is tolerant and you are able to abolish all episodes of apnea and hypoventilation in your level 1 sleep study, then probably you may not even resort to giving a bi-level devices or the BiPAP devices. So your bi-level essentially comes into the play when you have higher degrees of hypoventilation, where you keep on increasing the difference between the IPAP and the EPAP to support for the hypoventilation rather than actually an apnea. So this is a little technically challenging, but as you keep doing more of sleep studies, you understand how this actually works. And now moving on to Dr. Indranil Halder, sir, I think no talk would be complete without this, like the impact of neuromuscular disorders on sleep, because that is where actually the concept of entire PAP plays a very important role.
So yes, it's very important when it goes to neuromuscular. And if you see the mechanism again, the respiratory muscles, especially the diaphragm, weakens, lead to sleep hypoventilation. And it is more so starts with the REM sleep and gradually progress to the NREM sleep. So hypoventilation, nocturnal hypercapnia, and decreased ventilatory drive all contributes to it. And in addition to it, the upper airway and craniofacial weakness, there is also impaired cough, as we see, and there is secretion, and there is lack of clearance and postural discomfort, all contributes to the neuromuscular disorders and the obstructive sleep apnea as it's there. So if you go to the clinical impact, again, they are often present with daytime respiratory symptoms, and all other features that can be there due to the obstructive sleep apnea, leading to sometimes due to some acute or even acute on chronic respiratory failure. They also cause to have respiratory infections. And if you see the sleep architecture, also they have sleep fragmentation and worsen quality of sleep, and ultimately the quality of life in this neuromuscular disease also decreases.
Excellent points, Dr. Indranil sir. And to Dr. Harjit Dumra, I think the most important aspect with neuromuscular diseases, how to titrate optimal PAP settings. Because here we are not only dealing with apnea, here we deal more of hypoventilation. So when do you actually really start considering a BiPAP for these patients?
First and foremost, the cutoffs are obviously there on the lung functions, and you can look at the maximum inspiratory pressures, and the FEV wants to take a call, and there are guidelines as to where you should start. But the bottom line is that it is better to start early PAP therapy in patients with neuromuscular disorders, whether they are sleep apneics or not is besides the point, rather than late. Now, the combination of sleep disorder or a sleep apnea with a neuromuscular is like a double-edged sword. You're dealing with hypoxemia from the sleep apnea, and you're dealing with hypoventilation from the neuromuscular disorder. So vis-a-vis the other disorders, say, for example, airway disorders and sleep apnea, where you might give a trial of CPAP, non-invasive ventilation becomes the device of choice in these disorders. What you need to understand is that even if at the outset these disorders might be mild and you might get away with the CPAP, but most of the neuromuscular disorders are progressive. So eventually the patient will have to buy a non-invasive device. So in India, where the patient is paying for his own device, there is just one way to move forward, that is bilevel or non-invasive ventilation. And when we talk about non-invasive ventilation, there are a couple of things which you need to look at the outset. One is the interface which you will use. And here, why do I mention the interface? Because if you're picking up these patients late, some of these patients might have started aspirating a bit. These are groups of patients who probably at this point of time don't need a PEG or a tracheostomy, but they have just started. And here a nasal mask would be preferable than a full face mask, because if there is some element of secretions, at least a nasal mask will facilitate expectoration. Although that is not a major concern only at sleep, it is during daytime. The second bit is about which machine to use when you talk about non-invasive ventilation. And so a BiPAP with an ST mode, we need a backup rate in all these patients because many of these patients are hypoventilating. So you need a backup rate. So only a backup rate machine equipped with a backup rate can be used. If you have the luxury of buying a more expensive machine, and AVAPS is even better because it gives you an assured volume even as the patient progresses. The reason being is that many of these patients with neuromuscular disorders tend to have basal atelectasis. And if you do not deliver the adequate tidal volume, that will add to the secretions and will cause more of an issue down the line, which can be overcome with an AVAPS. Now, as far as titrating pressures is concerned, most of the principles are very similar to what we would do with a COPD patient or an overlap patient. You start with at least the EPAPs which you have picked up on the sleep study. So if you have had the luxury of doing a sleep study, you will have a pressure titration which will abolish the apneas, and that becomes your EPAP. And usually if you ask me, if the patient is not overtly obese, most of the times your EPAPs will be in the region of 5 to 8, and you can start with that. And what you need to understand is the tidal volume is generated by the difference between the IPAP and the EPAP. So if you have an EPAP, for example, of 6, you usually go with an IPAP of 16 to see how the patient is doing. Another challenge is because you're trying to look at the CO2 levels. Unless and until you have a transcutaneous monitor, you will not be able to titrate these patients to the optimum pressures. And sometimes doing ABGs is cumbersome, and hence many times a lot of us approximate the pressures rather than going for a perfectly normal ABG. So the bottom line is the patient should not be symptomatic. He should not be retaining secretions. At the same time, there should be no sleep fragmentation.
Yeah, perfect points, Dr. Hardik. For the audience here, the moment you see desaturation in these patients in daytime and you get an ABG, you are able to see a rise in the bicarbonate level. Ideally, it should be a measured bicarbonate level where you take it directly from the serum. That is the first point. You will consider hypoventilation in these patients and subject them for a sleep study and possibly put them on NIV. As Dr. Harjit said, it is all about an ST mode, because when they go into the REM sleep, they are going to go in for excessive levels of hypoventilation. So you should always have a timed ST mode, spontaneous and time mode. And if you have the liberty of an average volume assured pressure support, then possibly that is the best fit for these patients. So now we are going to have a quick rapid fire, because we have a lot of the questions from the audience. So to Dr. Samir, like a quick answers to the queries. So how ILD and sleep disorders are interrelated? Just 4 important points which you feel our audience should take home.
Yeah, so of course, because ILD, the main problem out here is reduced lung volumes, and further during sleep, the residual capacity reduces. So again, this worsens the overall hypoxia, and the nocturnal hypoxemia and pulmonary hypertension as a consequence of the whole thing. It just worsens quite significantly, putting again right ventricular strain. The systemic effects, of course, being there is a lot of inflammation, which leads to oxidative stress, and this can actually worsen your underlying ILD also because of all the cytokines, profibrotic cytokines, including the TGF beta. And this in general leads to sleep fragmentation, poor quality of life, and again the sleep fragmentation is not only related to the OSA, again related to the ILD related cough as well. So again, all in all, sleep fragmentation, reduced lung volumes, which further worsens the nocturnal hypoxemia, worsens your pulmonary hypertension, has systemic inflammation, leads to an increased progression of your ILD also. Just a very short and sweet sort of an answer.
Perfect points, Dr. Samir. And Dr. Harshini, you touched upon this. So let's say that I have an ILD patient who is already hypoxemic. So if I'm going to perform a routine sleep study, every of my event is going to come as apnea. So how do you really are going to identify obstructive sleep apnea in a patient who is already having a hypoxemia?
So the first thing doesn't start with the sleep study, but it starts with the pre-study preparation. So we need to go through all the documents, and we really need to understand what is their baseline oxygen. So what is their, if they're already on oxygen, if they're not on oxygen, say baseline is 90%, then we can start from there. But if they're already on oxygen, so then we need to do the sleep study with the oxygen intact. So otherwise, what happens is if they're going just to see how much will be the nadir SpO2, if you're going to see that in already hypoxemic patient, then they might land up in severe hypoxemia and arrhythmias and severe cardiac complications during the study itself. So pre-study preparation is quite important. Second thing is we need to make sure that they're not in exacerbation, and we need to see that they took their bronchodilators or inhalers promptly before the study. And we need to understand if they're on LTO2, and we need to go through their ABG, previous ABG reports. And during the study, if there is transcutaneous CO2, I don't think most of the labs will be having transcutaneous CO2 or EtCO2 in general. But if it is there, it's going to be much more helpful in these cases, since we'll have the previous ABG, and during the study, what is the nadir oxygen and what are the oxygen drops, CO2 levels we can identify. So while doing a study, the basic point is if the patient is on intermittent oxygen, before the study itself, we can check in the lab what is the least oxygen drop when they're awake. And if they're already on oxygen, we can minimize the oxygen level, and with resting SpO2, we can start. During the study, main thing for elevation of oxygen or to start a titration study, we need to see if the SpO2 is dropping below 88% for more than or equal to 5 minutes. Then we need to either increase oxygen, or if the diagnostic part is over, we can go for the CPAP titration. Or if the SpO2 is below 80% for more than or equal to 1 minute at any point, then immediately we need to increase oxygen or go for the PAP titration. So we should not think that we need to stop the oxygen in existing hypoxemia patients. I think that would be my baseline point.
Yeah, true. And Dr. Nitesh, quick answers like how to monitor hypoventilation during sleep. So what are the devices we have?
So we have 3 methods to do it. One is transcutaneous CO2 monitoring. Again, not much cannot be seen in many sleep labs in the country. It is mainly used in pediatric patients in their pediatric ICU when neonatal. They don't want to do ABGs again and again, so they monitor it through them. But it is obviously available in most of the high care centers. You can just ask the machine for a loan or for a night and do it in the patient. Second is your end tidal CO2 monitoring. The sampling line gives you the CO2 values, which the graph and as well as the values can be seen on the screen. The disadvantage of and tidal CO2 is you cannot use it during therapeutic portion because you need to remove the nasal cannula and then you need because you need to put the CPAP mask. Third method is a raw method where we have been taught that we see the desaturation graph if it is taking longer to fall and the slope is longer. That means there has been an hypoventilation rather than an hypoxemia or hypoxemia in that episode.
Yeah, any role of esophageal catheters to
right. So esophageal manometry also has been done. It only differentiates you to tell what has been the cause of apnea, hypopnea, whether the brain has given the signal to the diaphragm, or is it the diaphragm, the signal has been given, but diaphragm is not strong enough to induce the breath at that time.
Yeah. And hello, can you hear me?
Yes, yes.
So to Dr. Indranil, sir, like I think we heard a lot, but just quick 4 points on the impact of sleep disorder breathing on pulmonary vascular disorders.
So it has been discussed in length again that sleep disorder breathing causes pulmonary hypertension. So there is an associated increased risk of pulmonary hypertension and can worsen also pre-existing pulmonary vascular disease. So it induces, it is because of the intermittent hypoxia and increased blood pressure and elevated pulmonary arterial pressure that it causes the pulmonary hypertension. And again, if you see a patient the other ways, if you see a patient of pulmonary hypertension, the first thing that has to be done is to rule out OSA. And again, there are some studies which have shown that if you can treat the OSA or the sleep disorder breathing with PAP therapy, there is some reversal in the pulmonary hypertension or the severity of the pulmonary hypertension. So these are linked. And in fact, it should be kept in mind that the long-term OSA will ultimately cause pulmonary hypertension.
And your evaluation of pulmonary hypertension is never complete without a sleep study before you label them as a level 1 pulmonary hypertension. So to Dr. Harjit, quick points, impact of sleep disorder breathing on cough. Is there any relation per se, or it is just a bystander?
So many times it could be a bystander, and many times you would be pleasantly surprised that treating of sleep apnea can get rid of the cough. So I suppose if a patient who is obviously having obstructive sleep apnea, when you look at a patient, if he's obese and there are obvious symptoms like snoring and daytime sleepiness, and he's the one who's coughing, you would always dial in sleep apnea as a contributor to the cough, and obviously you address it. But many times I basically think of sleep disordered breathing when you have a refractory chronic cough. And that is the segment of patient populations where we seldom think of sleep apnea as a contributor. And there are several mechanistic links when you have refractory chronic cough. Say, sleep apnea will lead to repetitive airway vibration from the snoring. This leads to mucosal inflammation and that heightens the cough reflex. Sleep apnea leads to increased negative intrathoracic pressures, and then that promotes gastroesophageal and laryngopharyngeal reflux. Again, that drives the cough. Many times patients will have nasal pathologies with sleep apnea, and that leads to upper airway cough syndrome. In fact, in patients with asthma, there is intermittent hypoxia and inflammation, and then with sleep apnea, there is further inflammation, and that leads to worsening in a cough, which becomes difficult to treat even when you treat asthma and COPD. So you have an out of proportion cough in patients with asthma, COPD. Sure. And all of that sort of makes you think of sleep and cough being related in a lot of our patients. So think of sleep apnea if you have refractory chronic cough.
True. And Dr. Samir, I think it's a very interesting hypothesis. So sleep disordered breathing causes hypoxia. Hypoxia causes oxidative stress. So let's say can this oxidative stress cause carcinoma lung? So any data on that? You're on mute.
So I don't know whether per se, because the OSA will lead to carcinoma, but nowadays, yes, of course, we're seeing a lot of CA lungs in non-smokers and otherwise also without much exposure. So there's, yes, possibilities there.
But I believe like a few years back, there was one report, like a study which try to correlate this oxidative stress with
exactly. So the major thing is this only because, again, hypoxia, inflammation. So these are the two major things. Because of inflammation, all the factors, the HIF1 alpha and the TGF beta, and they have actually seen in the tumor tissues also, when they correlated, the levels have actually increased. So therefore, they linked it to a possible worse survival and rapid progression. Again, because of hypoxia, there is also increased angiogenesis, which is somehow linked to tumor progressions also. And many times, again, lung cancers are there in patients with underlying COPDs, and we've had a long discussion about COPD and OSA. So I think all of these factors possibly say that yes, sleep apnea, obstructive sleep apnea presence untreated and severe especially, may lead to an increased incidence of lung cancers, and yes, if you have, possibly resistance to treatment and further progression as well.
Yeah, and more than that, I think it influences their quality of life, which is what we are looking into. And one final question to Dr. Harshini before we take the audience questions. So, should we evaluate sleep disorder breathing in all patients with chronic lung disease? I think the answer is well written, but your comments?
So for me, I don't think we need to really do a sleep study in every COPD patient, but we definitely need to screen every COPD patient with the basic questionnaires. Because there is a high prevalence of sleep apnea in COPD, one thing, and even in ILD and other diseases also. So if I have to say in one line, evaluation of SDB should be a part of comprehensive care in chronic lung diseases, especially in high-risk groups. And if not a full PSD, at least a screening should be done. And in case of hypercapnias, chronic hypercapnias, or nocturnal hypoxias, or pulmonary hypertension, these patients, I think we should definitely go for, and whom we want to start NIV. So LTOD patients, I think these patients are the one in whom we should evaluate for.
Yeah, and I think our history taking should never end without questioning about this quality of sleep, which is unfortunately missed in many of the symptom evaluations. So I think we had an excellent panel discussion. Now, quick questions by the audience. We'll start with Dr. Harjit. So this is from Dr. Jai Kishan, pulmonologist from Punjab, Patiala. So any study of sleep disorders or OSA in children with autism or cerebral palsy? Dr. Harjit, we are not able to hear you. I think we'll take it from Dr. Sameer then. I think we lost Dr. Harjit, sir. Dr. Sameer, any study of sleep disorders or OSA in children with autism or cerebral palsy?
And I'm not very sure about this because, frankly, we don't see a lot of pediatric patients. I think Dr. Indranil will possibly be the best person to answer this.
So yes, Visweswaran, yes, definitely the answer is yes. So autism, we don't know, but cerebral palsy, children are prone to obstructive sleep apnea because of the neuromuscular weakness, because of the decreased secretion clearance, and because of the flabbiness of the upper airway that causes more of obstructive sleep apnea. So they should be screened if there is snoring, if there are restless, disturbed sleep, and restless sleep. So they should be screened for that. And if you want to have a statistics, how much percentage of this cerebral palsy patient, that has to be gone through the to find out the literature. But yes, we should have a good clinical suspicion and they should be screened for OSA. Just like Downs, as I call 2/3 of the patients of Downs may be having OSA and they should always be screened for obstructive sleep apnea.
Yeah, and to Dr. Nitesh, Dr. Hira Daldoria, consultant physician from Madhya Pradesh. So, what is the difference between ECOS and COPD OSA overlap?
So ECOS is asthma COPD overlap, where we have a patient who has had history of asthma, has been a smoker, and now presenting to us with permanent fixed airflow obstruction. Those are the cases where we label them. We used to label them as ECOS, and COPD OSA is something where patient will have nocturnal symptoms or maybe in respiratory failure, where you need to evaluate for sleep disorders.
Yeah, and to Dr. Indranil sir, Dr. Satyaranjan Panigari from Orissa, Bhubaneswar. Pediatric sleep disorders are very much underdiagnosed in India. How to address the parents? So, what is the parent counseling which you will give?
So again, as I told that every children, when they come to the clinic, should be asked about their snoring, their sleep history, whether the sleep is restless, enuresis at night, or learning disability, or daytime sleepiness, or growth retardation, growth failure, as we see. So again, if we have a high clinical suspicion, they should undergo pediatric sleep study. But what is important, again, we have lack of pediatric sleep lab. What most of the people are doing, converting the adult sleep lab into a pediatric sleep lab, not knowing fully what should be the scoring system, or even the pulse oximetry, what Nitesh was telling, that the pulse oximetry is done with an adult pulse oximetry. The leads are all adult, which should not be done, and we should have at least a few dedicated sleep lab in each central place, or even in every state that we should be expecting. So the concern is that we should at least address the consequences of untreated pediatric sleep apnea, and that should be addressed, and they should be told about the consequences both in neurological, neurodevelopmental, and the cardiovascular consequences, and what can be done if we can treat that pediatric obstructive sleep apnea. But what the otolaryngologists mostly are doing is that, without going for a sleep study, a child who comes to with snoring, they assess their adenoids, either by an endoscopic adenoid evaluation or by an X-ray adenoid evaluation. If they find that the adenoids are enlarged, they go for a surgery to treat the obstructive sleep apnea in this children. Even without an enlarged adenoid, if the child is snoring and having features of obstructive sleep apnea clinically, they go for a surgical just clearance and the ablation of the adenotonsillar, and they think that probably that will be treating them, and without even seeing for residual obstructive sleep apnea in these patients. So it is only because of the lack of sleep lab in our most of the places in India.
I think we need to create a lot of awareness even amongst the doctors and the practicing physicians as well. So another question from Dr. Mehak from Maharashtra, Mumbai, to Dr. Harshini. Quick answers. What are the symptoms of OSA in children? I think we dealt in depth, but still.
Yeah. So if it is quick, then it is snoring and mouth breathing in the night time. We can see parasomnias or like sleepwalking or, nightmares and bruxism. And in the daytime, hyperactivity, not having good attention, and lack of focus. Then they don't progress very well in their milestones, whether academic or developmental milestones as well. And there's the excessive nocturia. So even after 7 years of age, we see excessive nocturia in these kids. I think this is a summary of symptoms in pediatric.
Yeah, perfectly pointed out. And there's a question to me, Dr. Shadambikar from Maharashtra, Thane. How does sleep architecture change in patients with chronic lung diseases? Yes, it changes. It has got both cause and effect relationship. So you'll have more of sleep fragmentations. You'll have more of REM associated hypoventilation, severe nocturnal desaturations, worsening of your underlying pulmonary hypertension, and fatigability in the daytime, excessive daytime sleepiness. So I think both are related and we dealt in depth. So now we move to Dr. Samir. This is Dr. Tanmay Maitra from West Bengal. So long continuation of nasal steroids may give any benefits for patients with sleep apnea. Your take?
Again, I mean, it depends whether these are absolutely necessary or not, because if there is no indication, there is no turbinate hypertrophy, allergic rhinitis, I doubt they will help in these patients. Yes, there has been some indication in maybe pediatric age group, but definitely not in adults. Yes, when they have seasonal rhinitis, allergic rhinitis, then definitely, but otherwise there is no role per se of just nasal sprays.
I think if you have the symptoms, then yes, possibly yes. And again, we have a question from Dr. Ravi Yadav from Maharashtra to Dr. Harjit Dumra. How does REM sleep physiology impact gas exchange in patients with chronic respiratory patients?
So I think because in REM sleep, diaphragm is the only muscle which is active, and the intercostals and other muscles do not contribute. Any patient with chronic respiratory diseases, the problems will get compounded because they are functioning already at a lower respiratory reserve. So any disorder of sleep in any patient with chronic respiratory disorder would be more manifest in REM sleep than in non-REM sleep.
Yeah, perfect. And Dr. Krishna Gohil from Thane again. This is to Dr. Nitesh Gupta. How does nocturnal hypoxemia differ in stable versus a stable COPD patient versus a COPD with a coexistent OSA? Nocturnal hypoxemia.
Right. So if a patient who just has stable COPD, so there we'll see the sawtooth pattern that oxygen is falling, it is picking up, falling, picking up. We see a sawtooth pattern on our basic nocturnal oximetry. However, if patient has concomitant OSA, we'll start seeing features of apneas, hypopneas occurring in addition to nocturnal hypoxemia. So that is how we start appreciating that patient is concomitant OSA also, apart from just having a hypoxemic respiratory failure.
We have another question from Dr. Kirshiv Somaya, pulmonologist from Gujarat, Valsad. So this is to Dr. Harshini. What mechanisms explain increased exacerbation rates in patients with COPD with untreated OSA?
So I think the intermittent hypoxia and oxidative stress, this is one thing. And second thing is a systemic inflammation. There's an immune dysregulation, and there's an increased airway collapsibility, and there's a poor mucociliary clearance. So finally, there's cardiovascular and autonomic instability. And also in deep sleep, when the patient goes into REM sleep, so there'll be muscle atonia, and this also exacerbates. So I think these are all the mechanisms.
Yeah, I think even the similar question was asked by Dr. Komal Pansade. So we move on to the next by Dr. Rakesh Tripathi, pulmonologist from Bihar. How does hyperinflation in COPD worsen nocturnal desaturation? To Dr. Indranil, sir.
So hyperinflation is there, and that is the decreased gas exchange. So this all contributes to nocturnal hypoventilation and ultimately severity of OSA in patients with COPD.
Yeah, and we have a question by Dr. Rakesh Angala from Hyderabad. And this is to Dr. Samir. How do sleep disorders affect pulmonary rehabilitation outcomes in ILD?
Yeah, so
I think this must be something close to your heart, you running a rehab center.
So I think it's not really that it affects the pulmonary rehab outcomes. It's basically the ability to perform rehabilitation rather, because sleep fragmentation doesn't allow, it causes inflammation. It doesn't allow the patients to have a restful night. And that is where they're always tired and they become more resistant or apprehensive to start with a rehab program. But typically what we've seen, all these patients who have more of these symptoms or other patients who are worse, with worse scores on the fatigue severity scale, they actually benefit much more with rehabilitation. In fact, it improves their quality, the sleep quality as well, is what we've seen. And in fact, we'll just come out with this paper as well.
So in fact, Visweswaran, today only in the paper, I got a review that the blowing of conch can decrease the severity of OSA. So there are studies from India which are going on and has been published in some peer-reviewed journal that blowing of conch may decrease the severity of the OSA. Though this may be in one of the rehabilitation programs with patients of this OSA.
Yeah, very true, sir. Very true. And again, another question from Dr. Parcha from Mumbai. This is to Dr. Harshini. How does sleep deprivation affect airway hyperresponsiveness in asthma? So again, the effect of sleep on asthma.
Yeah, I think again it's the same. So there's an immune dysregulation mechanism, and there's, when you don't sleep, basically sleep is one thing where restoration happens. So again, the inflammatory response or the immune dysregulation and the cytokine release. So all these things play a role in exacerbation of asthma. I think these mechanisms do contribute.
And Dr. Gurmeet Singh Chabra, pulmonologist from Haryana, Faridabad. So to Dr. Harjit, safe antidepressants of choice in patients with COPD OSA overlap. You are on mute, sir. Kindly. Yeah.
So basically, although the SSRIs can compound the sleep disorders, but most of the times you can use fluoxetine, and sometimes I've also used the escitalopram and combinations. But usually I tend to talk to my psychiatrist and ask him specifically as to what would be the best option in a given patient, and tend to emphasize that my patient has a sleep disorder. So he has to take into context respiratory depression when he prescribes antidepressants to these patients. So it is again multidisciplinary as far as use antidepressants go.
Yeah, and I think never over the counter pills for sure. So, and Dr. Jatin Dalal from Bangalore. This is to Dr. Nitesh. In your clinical experience, how often do you see sleep disordered breathing coexistent with COPD, asthma, or ILD? Like, let's say a score of 10, how many patients of COPD would have an underlying OSA in your experience?
So as I have shown you, the prevalence range from 3 to 70%. So it's all about how much you are asking. The more you will ask, the more you will evaluate, the more will be the prevalence.
Yeah, I think you screen more, you pick more, and you treat more. So this is another question by Dr. Nirav Gondiala from Gujarat, Surat. Myself, Dr. Nirav Gondiala from Surat, Gujarat. It was an excellent session. Just enumerate most important features to differentiate patient having obstructive airway disease, having OSA. Again to Dr. Samir. Quick take. I think we spent a lot of time
I
on it,
think we
but quick
just
take.
discussed this at length. So the major thing is, okay, the worsening of symptoms, more fatigability, increased hypercapnia, increased hypoventilation, and an increased degree of hypoxemia, along with overall other systemic inflammation signs, can point towards a patient having OSA as well. And of course, pulmonary hypertension, disproportionate. These are certain things which can point towards a patient having OSA.
And to Dr. Indranil sir, this is from Dr. Kamalpreet Singh, Ludhiana. Should routine pediatric health checks include targeted sleep disorder screening?
Absolutely, yes. So only thing that should be asked in the question is whether the child snores or not. This questionnaire based. So to increase the pretest probability of suspecting OSA in the pediatric age group, then restless sleep, disturbed sleep, bruxism, a nocturnal enuresis, or learning disability, or excessive daytime sleepiness. So this should prompt us to do a sleep study in this pediatric age group.
Yeah. And to Dr. Harshini, this is a question from Dr. Jaimin Patel from Ahmedabad. How significant is the role of adenotonsillar hypertrophy versus obesity in pediatric OSA? Quick take.
So adenotonsillar hypertrophy, I think it's still the most common cause of OSA in Indian context. And even these days, we see in adults also, there is a lot of adenoid hypertrophy. So for even if we leave children, even adults are having that. So that is one thing. And versus obesity in urban population, we see a lot of obese kids, whereas in rural population, still obesity is not a major cause of pediatric OSA.
Yeah. To Dr. Nitesh, Dr. Jasmine Guha from Guwahati, what are the key differences in managing sleep disorder breathing in children compared to adults? Just 4 important points.
So one is the causes are different. Children may have more of anatomical factors, so it will require a correction. Adults do not have that much anatomical factors, so CPAP remains the primary line of treatment and titrating it better. Control of comorbidities, if there are any. So these are the 2 things which I feel are the most
and
important.
the AHI scoring is different in adult and pediatric as well. So to Dr. Harjit, Dr. Tanvir Ahmed from Kanpur, how does untreated OSA in children affect growth, cognition, and behavioral outcomes? I think quick take.
Harjit is not here. Harjit is
okay. And to Dr. Indranil, sir.
Yes. So this has been told that untreated obstructive sleep apnea affects growth in terms that it may cause stunted growth, even cognition. Definitely neuropsychiatric manifestations are there. It will affect the cognition and behavioral outcome. So this has been told repeatedly and it will affect.
Yeah. And Dr. Samir, quick take, Dr. Murli from Hyderabad. Why do pediatric sleep disorders often remain undiagnosed and most common signs missed by both parents and physicians?
So I think one of the major things is, of course, lack of awareness and yes, lack of acceptance also. And the second thing is many a times patients take this for occasional, maybe a nose block or rather, just a habitual snoring. And that is where they keep ignoring it. And the same thing is, as far as physicians are concerned, I think it's just the lack of awareness or possibly, just that routine practice of just screening patients, all the pediatric patients for OSA routinely.
And Dr. Nitesh, again, this is from Dr. Jitin Cochin. So what gaps exist in the current guidelines on public policies for integrating sleep disorders into chronic respiratory care? I think you are the right person. You're working in a government institution.
So the guidelines, right now we do not have mandatory screening.
I think you should make the guidelines soon, sir.
Sure, we will work on this. We can work on this. So it is about screening. The more you ask, the more you will detect. It's very simple.
Yeah. And to Dr. Indranil sir, Dr. Yash Dayal from Haryana, how do you tailor the PAP therapy for sleep interventions for patients with advanced COPD or restrictive lung disease? Quick points, sir.
So COPD has already been told. First start with CPAP. Then if required, we can move on to other PAP therapies. And restrictive lung disease, again, CPAP is the, we can have CPAP titration and find out the right pressure that is there. Auto CPAPs are there, but again, the CPAP titration is one that I find suitable and it should be used in the best
Yeah,
of it.
and to Dr. Harshini, Dr. Manish Singh from Lucknow, should sleep assessment become a standard of chronic respiratory disease management protocol in India?
Yes, definitely yes.
And which questionnaire would you choose, if at all given a choice of one at least?
So I think so far, whatever we've been doing, the Epworth Sleepiness Score or...
No, if at all I give you a choice, like one you have to choose in a OPD or in a screening?
I think I choose top bank only.
Top bank, right. And to assess for response, you choose a Epworth Sleep Questionnaire, right?
Epworth Sleep Questionnaire, yes.
Yeah.
Because Epworth Sleep Questionnaire, it's only targeting the daytime sleepiness.
Daytime sleepiness. So response to your PAP therapy can be evaluated with your ESS.
Yes.
Yeah. And this question is to Dr. Samir again, Dr. Ajay Langekar from Maharashtra. Experience with AVAPs and availability for domiciliary use?
So one, yes, AVAPs is definitely a useful machine, and typically patients who have a lot of hypoventilation, neuromuscular disorders, these are the patients which we typically or specifically tend to tell them, okay, if you can afford, please go for an AVAPs machine. It is widely available. I don't think it's a problem, especially in cities.
Only thing you need to specifically ask for it.
Definitely do BiPAP machine, bilevel PAP with an AVAPs mode is something.
And as Dr. Nitesh says, like ask it, you get it. Yeah. So again, one question from Dr. Manish Singh from Lucknow: should sleep assessment become a standard? Okay, that we have done with. And Dr. Smita from Mumbai: how does untreated sleep apnea or nocturnal hypoventilation affect long-term outcomes in chronic respiratory disease? Dr. Nitesh, I think quick points, 1 or 2 points on this.
So as I showed you in my slide set, it is the nocturnal hypoventilation where first we have hypercapnia in the night. Untreated, it spills over to the daytime. So there you have diurnal respiratory failure. So untreated patients will definitely end up in the daytime hypercapnia also over a period of time.
Yeah. And to Dr. Harshini, Dr. Hemant from Jaipur, what are the early indicators in chronic respiratory disease that should prompt the screening for a sleep disorder?
So I think they will be telling us about the apnea spells, sleep maintenance issues, especially sleep maintenance, insomnia, sleep fragmentation. So they'll have headaches, so which they might not be having before because of the hypoxia. So these are few things which we commonly observe. And excessive nocturia is one thing, and of course pulmonary artery hypertension if they're having, and systemic hypertension or cardiac failure they're developing. So these are all the things which actually makes us screen for OSA.
And there's a question to me by Dr. Shadambikar from Maharashtra: how does transcutaneous CO2 monitoring help in detecting nocturnal hypertension? So as we spoke earlier, there are two ways of measuring it. One is end-tidal CO2 and the transcutaneous. So end-tidal CO2 can be affected by your breathing pattern, and even when you are using a PAP devices, so we don't use it during the titration part of the study. Whereas your transcutaneous CO2 monitors are available, but they are quite expensive to use, predominantly used in pediatric setting. And it is placed over the skin where it heats the skin, causes a vasodilation, measures the CO2. But the problem with that is it can't be placed for very long, prolonged periods of time because it causes the heating of the skin. Though new monitors claim that they don't heat up to that level, it is not something which is routinely available across all sleep labs. But if you are titrating for hypoventilation and you want to measure, then possibly transcutaneous CO2 is the best thing that is available. So again to Dr. Indranil sir, Dr. Nirav Gondiala from Gujarat again, every OAD patient should be screened with stop bank questionnaire. Is it correct or wrong? You're on mute, sir. You're on mute.
Very easy tool. Why no harm to do the stop bank questionnaire? If there is a high clinical suspicion, then yes. But again, a stop bank questionnaire was initially developed for the anesthesiologist for a pre-op evaluation, but you can use it for OAD patients.
Yeah. So Dr. Nitesh, Dr. Dinesh Kumar from Uttar Pradesh, Ghaziabad, any role of endoscopic mucus clearance in patients with difficult COPD and OSA along with hypoxia?
Not to best of knowledge. There is no role of mucus clearance either in COPD or COPD with OSA.
Yeah. And to Dr. Harshini, Dr. Nirav Gondiala from Gujarat again, safest mood elevator for patients having OAD with OSA? Any drugs?
Sertraline is one thing which is commonly given by our psychiatrists because we do an integrated approach in our center. So most of the times what I see for mood elevators is sertraline. And if we want to choose anything for sleep apnea and insomnia, then zolpidem and lambroxan newer molecules. These are the most commonly used molecules.
Yeah, and again, one last question to Dr. Indranil sir. Dr. Ajay Langeshwar from Maharashtra again. Bariatric surgery for morbid obesity with severe OSA or obesity hypoventilation, your take?
Yes, bariatric surgery is one option that is there left. But again, there has its own limitations, and there are specific indications where bariatric surgery can be done on very high BMI patients with having OSA or OHS. But again, it has its own limitations, and all thing has to be matched.
Yeah, and I think now we have got some better pharmacological drugs for obesity as well. So I think there are no further questions, and we have crossed the time limit by almost half an hour. So I'd like to thank all my panelists for taking their valuable time. Also thank the ICS, Mr. Nitesh from CIPLA, and I was informed that we had 2,592 doctors who have logged in for this web meet. So that shows the interest they have in the updating themselves about the sleep medicine, which is a good sign. And I think hopefully we deliver to your expectation, and maybe for a next web meet soon, we will catch up. Till then, thanks and goodbye from all the panelists here and myself, Dr. Visweswaran, who was your moderator. Thank you.
So thank you all.
Thank you all. Thank you.